Well, good afternoon and welcome to the Australian Ethical Health Alliance 2022 Symposium, COVID and Equity. My name is Adrian Cosenza. I'm the chair of the Australian Ethical Health Alliance and also the Chief Executive Officer of the Australian Orthopaedic Association. In the spirit of reconciliation, we acknowledge the Gadigal people upon whose land we meet today and the traditional owners of country throughout Australia and their connections to land, sea and community. We pay our respect to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today, and by all means acknowledge the traditional owners of country from wherever you are participating today. Just a few housekeeping things. Your participation in today's symposium, it's a webinar. Attendees are allowed to chat with the panellists only, and you can see there where we've highlighted that. And by all means, please feel free to submit your questions through the Q&A feature, and all questions will be seen by the audience. I'd like to particularly welcome our Auslan interpreters. AEHA is absolutely thrilled to welcome Dave Childs and Nicole Meyer to provide sign language throughout today's symposium. Our sincere thanks to Dave and Nicole. So what is the Australian Health Consensus Framework in the healthcare sector? It's a consensus of shared values and ethical principles that form the basis of collaboration and interaction amongst organisations in the healthcare sector. This group has developed a series of substantive principles and a series of procedural principles that comprises the Australian Consensus Framework. There are 78 members representing the Australian population and about over a million health professionals, employees and trainees that are part of this alliance, and they come from all sectors. It's been reported by others that it is the largest consensus framework of its type presently anywhere in the world. The Alliance was formed in 2019 as the leading body to guide the implementation of the Australian Consensus Framework. The vision, curated by the community, is to achieve an equitable, sustainable and ethical health system that advances the health, well-being and interests of patients, communities and the healthcare sector. The purpose of the Alliance is to promote collaboration and interaction, to enhance integrity and trustworthiness, promote public confidence and trust, and as we see today demonstrated by the symposium, to really encourage dialogue about ethics and equity. There are three key areas of focus that the Alliance is working on: advocacy and awareness throughout the membership, seeking to embed ethics in organisations and provide guidance and assistance, and work hard on organisational sustainability. Ethical practice is achieved when leaders and their organisations manifest ethical values and virtues, such as integrity, accountability and trustworthiness. That organisations are clear about their ethical obligations and aspirations, and organisations lead and shape ethical debate across the sector and more generally. And with that very short overview, it's my great pleasure to introduce our symposium moderators, Professor Ian Kerridge. Ian is Professor of Bioethics and Medicine at Sydney Health Ethics at the University of Sydney and staff haematologist and bone marrow and transplant physician at Royal North Shore Hospital. He's a member of the Health Ethics Advisory Panel for the New South Wales Ministry of Health, a director of Praxis Australia, and a member of the AEHA Steering Committee representing the College of Physicians. Welcome, Ian. And also absolutely delighted to welcome Dr. Claire Hooker, who is the Associate Professor at Sydney Health Ethics and President of the Arts New South Wales Arts Health Network, New South Wales ACT. Claire undertakes research and advocacy in risk communication, particularly in relation to infectious disease, and has been a frequent media commentator on risk communication about COVID. I now hand over to our moderators. Thank you.
Thanks, Adrian. So yes, my name's Ian Kerridge, and I'm speaking to you today from Royal North Shore Hospital, which is on Camaragal lands. Now, in the middle of the floods of the effects of climate change, the conflagration that's happening in the Ukraine, the COVID-19 pandemic in a way seems to have faded from view. But of course, it's actually consumed us locally and nationally and internationally for the last 2.5 years. And just to remind us of its impact, some figures, and recognising that these figures are likely to be gross underestimates. So globally, there's about 625 million people have been infected. Of those, 6.5 million have died. In Australia, 10.3 million people have been infected and almost 15,000 people have died. And globally, that represents about 3% of all of those people who've been infected dying as a result of COVID-19. Now, in response, and the figures are extraordinary, aren't they? They're the types of numbers that are just almost inconceivable. Now, in response, though, is that we've seen a remarkable transformation of our societies and also of our health systems. We've seen new drugs developed, sotrovimab, Paxlovid, Evusheld, molnupiravir, etc. We've seen a raft of new vaccines developed in rapid time. And these vaccines have been rolled out also in rapid time. Globally, 65% of the world's population has now had a single vaccine. Although much lower in low-income countries, which raises the type of issues that we can talk about today. And in Australia alone, 63 million doses of COVID-19 vaccines have been administered, although again, in lower numbers in different communities. Now, of course, COVID-19 is not just a public health issue, it's a social one, it's an economic one, it's a cultural one, and it's also an ethical one. And it raises a range of ethical issues. Now, in part, this is because pandemics affect individuals and families as much as they do communities and societies. In part, it's because, as with all public health crises, they foreground the very idea and the functioning of government. In part, it's because pandemics impact not just patients and families, but also health providers, and that then itself cause extraordinary distress and exhaustion. In part because pandemics expose and exacerbate existing tensions, inequities and indifferences. In the United States, obviously this has been according to race and access to healthcare, but in this country, arguably also according to age, to the presence of living with disability, to geography and to race and ethnicity. And finally, ethical issues emerge from pandemics because pandemics expose what we as societies value, what we want from our governments, and how we view each other and want from our societies. So in that sense, the broad ethical issues that emerge in relation to pandemics are ultimately about issues of equity, about fairness, about how we see each other, about whether we trust each other and trust our governments, and about the kind of society and country we wish to live in. So today we're going to hear from 4 remarkable speakers, each of whom will offer reflections on Australia's experience of COVID-19 and the response to it, and especially on the impact of the pandemic and our response to it on different communities, the elderly, people living with disability, First Nations people, and on social equity. Now, this discussion is not meant to valorise Australia's response or to emphasise how everything is fine, everything's gone flawlessly and there's been no problems at all. But nor is it meant to suggest that everything has been shambolic and harmful and our response has been disastrous. I think what Adrian and Claire and Rob and Talissa and I are hoping, and all of the AEHA are hoping, is that this will open up space for a more nuanced and respectful space for discussion about what has been done well, what issues have been exposed, what has been learnt, and what could be done differently in the future. And of course, as Adrian's pointed out, this is our view in broad terms of what the AEHA can and should do. So the session's going to proceed as follows. Each speaker is going to have approximately 10 minutes to speak. There won't be questions immediately after each speaker. Instead, when all of the 4 speakers have finished, my wonderful colleague, Claire Hooker, will lead a discussion with our speakers. For those who wish to make comment, please do so during the Q&A function, and we will honestly try and get to it if time permits. We will be finishing at 1:30, following which there'll be a recording of the webinar, which will be available to registrants. So to our first speaker. Many of you will know the names of our speakers, which is incredibly gratifying to the organisers. So the first speaker is Professor Michael Kidd. Michael is Deputy Chief Medical Officer and Principal Medical Advisor with the Australian Government Department of Health and Aged Care, where he's leading Australia's national primary care response to the COVID-19 pandemic. He's also a Foundation Professor of Primary Care Reform at the ANU. He's a general practitioner. He's a past president of the Royal Australian College of GPs, a past president of the World Organisation of Family Doctors, and a past dean of the Faculty of Medicine, Nursing and Health Sciences at Flinders University. So he's clearly deeply underqualified to talk to us today. So Michael, welcome.
Thank you, Ian, and thank you, Claire. And my thanks to Adrian and AEHA for the opportunity to join you for this symposium on COVID and equity. And I also acknowledge the traditional owners of the lands on which each of us is meeting today. I'm speaking to you from Ngunnawal country, the land where Canberra is situated. I also pay my respects to all First Nations people joining us on today's webinar. I want to say a special thanks to the Australian Ethical Health Alliance for your important work, and especially your role, as Adrian has outlined, in guiding the implementation of the Australian Consensus Framework for ethical collaboration in the healthcare sector. And I want to say thank you to everybody on this call. Thank you for the work that you've been doing over the past nearly 3 years to ensure that equity of access to healthcare services is available to all people in Australia during what have been very challenging circumstances. From the very beginning of the COVID-19 pandemic, the need to always keep ethics front of mind has been evident, as it is in all public health emergencies. Early in 2020, if you think back, we were watching in alarm the imposition of stringent public health measures in Wuhan and then in other parts of China, including the enforced isolation of large numbers of people in their own homes. And I know many of us were thinking that could never happen here in Australia. We then followed the sequential restrictions on travel being imposed by many countries, including Australia. And we then saw the tragedy of overwhelmed health services, initially in northern Italy, with horror reports of the decisions being made about who would and who would not be admitted to hospital, be admitted to an intensive care unit, be placed on a ventilator, and who would be sent home to die. We watched what was happening abroad, but we also acted swiftly in our own preparations and responses to this pandemic. Significant efforts have been made in Australia and internationally, and continue to be made, to identify and analyse the ethical implications of people's experiences of the COVID-19 pandemic and the impact of the responses to the pandemic, including public health measures and other government policy decisions. In March of 2020, the Federal Health Minister, the Honourable Greg Hunt MP, established the National COVID-19 Health and Research Advisory Committee and invited me to co-chair this committee with Professor Sharon Lewin from the Doherty Institute. 6 weeks later, we delivered a report on ethical issues arising from the pandemic. And this report was developed in partnership with members of the Australian Health Ethics Committee. Some of you are on this call today, a committee of the National Health and Medical Research Council, the NHMRC. And we also had contributions from the Consumers Health Forum, the Council of the Ageing, and many other representative organisations. The report made 2 important recommendations, which then had a flow-on effect into government policy. The first recommendation was that a range of ethical issues needed to be addressed to support government decision-making during and after the pandemic. And these included the need for well-coordinated and clear messaging to build public confidence and ensure that people in need of critical healthcare services knew that they were available and how to obtain them. It also included the need for planning to help to alleviate and not reinforce existing systemic inequities, especially those affecting members of Aboriginal and Torres Strait Islander communities, members of rural and remote communities, people with special needs, including those with disability, and older people. It also included resolving inconsistencies in jurisdictional policies on the allocation of resources. And it also included the importance of segmented communication and health promotion strategies to different priority populations, including people from culturally and linguistically diverse backgrounds. And finally, it included assessing why regular users at that time, in May 2020, were underusing healthcare services during the pandemic, especially during periods of lockdown. There was particular concern at that time that those requiring services to support them during the crisis, such as primary care, counselling, allied healthcare, and so forth, many people were not accessing these services due to fear of leaving their homes, self-isolation, lack of confidence, and confusion. The second recommendation from this report was the need to genuinely engage with and promote the active participation of the people most affected by systemic inequities in order to prevent reinforcing inequities throughout the pandemic response. COVID-19 has certainly shone a spotlight on populations of people who are at greater risk of missing out on public health messaging, public health interventions, vaccines and treatments, and equity is a fundamental issue. And that's why advisory groups were established very early on by the Commonwealth to ensure that the voices and the specific needs of priority populations were included in our national responses to the pandemics. We have groups for people with disability, people from COLD backgrounds, older people, especially those residing in residential aged care or receiving home care services, people receiving home-based palliative care services, people living in rural and remote areas, and many more. Importantly, at the very earliest stage of the pandemic, we established the Aboriginal and Torres Strait Islander Advisory Group on COVID-19, co-chaired with Nacho, to provide government with advice on culturally appropriate responses to the impact of the pandemic on Indigenous people and communities. So I want to focus on a few of the areas where ethical challenges emerge, particularly around access. And the first is on our national rollout of COVID-19 vaccines. You may recall that the vaccine rollout began in February 2021, and it began with a phased rollout to priority population groups. These included aged care and disability care residents, the staff of aged care and disability care facilities, the people working in quarantine and on our borders, and frontline healthcare workers who are working directly with people infected with COVID-19. Our vaccine program had vaccines provided free of charge and vaccines available to all people in Australia, not just Australian citizens and those who are Medicare eligible. The second phase of the vaccine program commenced a few weeks later as more vaccine supply came into the country. And that phase targeted all people in Australia aged 70 and above, all Aboriginal and Torres Strait Islander people aged 55 years and above, younger people with underlying medical conditions, including those with disability, as well as all other healthcare workers and critical and high-risk workers in areas, people working in defence, in the police, in fire services, emergency services, and also those working in meat processing areas. You may recall initial outbreaks in abattoirs and other meat processing facilities. These priority groups were identified by taking into account the public health, medical and epidemiological evidence on who would be most at risk of contracting COVID-19 or of becoming seriously unwell if they contracted COVID-19. Similarly, prioritisation of those most at risk has also been the case with the rollout of the oral antiviral treatments, Lagevrio and Paxlovid. Even before these treatments were listed on the Pharmaceutical Benefits Scheme in March of this year for Lagevrio, May for Paxlovid, initial supplies were pre-deployed in February from the National Medical Stockpile to all residential aged care facilities in the country and to all Aboriginal community-controlled health services and the Royal Flying Doctor Service to support the management of outbreaks in people who were highly vulnerable if they contracted COVID-19. Pharmaceutical Benefits Advisory Committee looked at the evidence and it recommended access to these treatments by those most at risk of severe illness and death from COVID-19, including older people and those who are immune compromised. And the decision on listing Lagevrio on the Pharmaceutical Benefits Scheme was the fastest listing of any medicine in the history of the PBS. The government, through the National Medical Stockpile, also deployed supplies of oral antiviral treatments to all state and territory health departments for use at their discretion with priority populations, including those people in their communities who were not eligible for PBS prescriptions. One of the most important areas of focus during the pandemic has been aged care. Most of Australia's 3,000 residential aged care facilities have experienced an outbreak in the past 12 months. And the Department of Health and Aged Care has provided a range of supports to the aged care sector. Advice was sought from the sector, directly from residential aged care facilities, but also from the National Aged Care Advisory Group, which I also chair, and which has informed the Australian Government response and the Australian Health Protection Principal Committee. Speaking directly to residents and their representatives and involving them in decision-making processes, including on vaccination and the use of antiviral treatments, has also been important in putting ethics and access front and centre. Ethical considerations were also front of mind in discussions about mandating vaccines for aged care workers, balancing the public health imperatives, workforce considerations, and individual choice. In 2021, Australia adopted national mandatory vaccination of our nation's aged care workforce in a successful staged rollout. Another critical ethical issue has been requiring aged care providers to maintain residents' social contacts and continued access to loved ones throughout the pandemic through the adoption of a code of conduct on visitation for facilities. Communication in the pandemic has also been key, and never before have we needed to convey public health information with such a diverse breadth of audiences all at once, and also quite complex information which at times was changing, leading to the risk of confusion for the public. Ensuring equity of access to public health information continues to be critical to our ethical response to COVID-19, including provision of information in many languages. From very early in the pandemic, there was concern about the risks of COVID-19 transmission posed to people with disability. And we saw the terrible impact of COVID-19 on group homes for people with disability, especially in the early phases in New York and elsewhere. We've had a Disability Advisory Committee, which has been meeting regularly since March of 2020, involving people with lived experience of disability, medical practitioners, academics, and others. And recently, this committee's advice has expanded the access of, or seen the expansion of access of the oral COVID-19 treatments to cover people with disability at greater risk. And also we've seen, based on their advice, the inclusion of children with disability in the vaccine recommendations for children from age 5 to 12. Finally, in an interview in March 2020, my first press conference with the Prime Minister of the time, I stated that there would be many reviews of Australia's COVID-19 response, and that's a good thing. We've seen one review, the Shergold Review, published in this past week, but there have already been many others, including the COVID-19 report from the Aged Care Royal Commission, recommendations issued by the Disability Royal Commission, the Hotel Quarantine Inquiry in Victoria, led by the Honourable Jennifer Coate, the independent inquiries into aged care outbreaks at Dorothy Henderson Lodge, Newmarch House, St Basil's and Epping Gardens in Melbourne, led by Professor Lynn Gilbert and Professor Alan Lilly, as well as coronial inquiries, the current House of Representatives inquiry into long COVID, Jane Holton's recent review of vaccine procurement. These reviews and continuing reviews throughout the pandemic have been incredibly important, again, in shining a spotlight on areas where we needed to modify our responses and ensure greater access for the people of Australia. They also provide a very important historic record of the lessons that must not be forgotten for future responses. It is my hope, however, that these reviews also focus on the many things that Australia got right in our response to this pandemic, so that we can learn from our successes as well as from our shortcomings. Throughout the pandemic, my own research team has been publishing details of Australia's pandemic responses to share our experiences with the rest of the world. And such publication of our experiences is also an ethical imperative. I'll leave it there. Thank you.
Michael, thank you. That was an incredibly eloquent overview, both of the pandemic and particularly our response to it. And thank you particularly for your summation of all of the reviews that have been happening over this period of years, because I think many, and I would include myself among them, haven't heard them all grouped together like that. So perhaps if we get time later on, we might think about how we can retain the insights of those reviews so that they don't fade into history and need repeating the next time there is a pandemic. But that was really wonderful way to start us off. Thank you. So our next presenter then is Professor Jackie Scully. Jackie is Professor of Bioethics and Director of the Disability Innovation Institute at the University of New South Wales. She's a scientist, a philosopher, and a psychologist with expertise in bioethics in a range of different areas, and is world-renowned as an extraordinary scholar in all of these fields. Jackie also currently serves on or chairs several local, national or international bioethics committees, and has had some statements relative to the pandemic through these as well, including the Australian Health Ethics Committee, the New South Wales Health Ethics Advisory Panel, and the National Disability Research Partnership. Jackie's also a Fellow of the Academy of Social Sciences, the Royal Society of Arts, the Royal Society of New South Wales, and the Hastings Centre. Jackie, welcome.
Thank you, Ian, and thank you everyone for the opportunity to take part today. And I'd like to acknowledge that I'm speaking from unceded Camaragal land. I'm going to focus on the inequities of the impact that COVID-19 had and the pandemic measures had on people with disability. And I note that I've experienced and continue to experience the pandemic as a bioethicist with a particular interest in disability ethics, but also as a disabled person active in the disability community. Next slide, please. You don't need me to tell you that people with disability were a marginal and are a marginalised community among the most vulnerable and most severely affected by COVID. And this has been amply demonstrated by a whole raft of statements of concern and targeted strategies and post hoc reports, from the Disability Royal Commission's first statement of concern, which was right at the start back in March 2020, through a number of others that I won't list, right down to the most recent Shergold report, Fault Lines, the independent review a week or two ago. All of these have raised and rehearsed very similar problems, some successes, but also failures on the part of government and healthcare providers. Next slide, please. Now, the disability community as a whole spoke up about its concerns about what was going to happen during the pandemic from the very earliest days. The initial worries, as some of you will remember, were about access to critical care and the potential for discrimination in situations of triage. These concerns were in response to the publication of critical care guidelines, mainly but not solely in the United States, which either said directly or implied indirectly that in at least some cases, disability per se could or should be a criterion for exclusion from access, for example, to ventilators or to intensive care units when those resources were under pressure. And although we know that the situation never became quite that acute in Australia, and fingers crossed never will, these concerns were real enough that the Australian Federation of Disability Organisations issued a statement of concern to which I contributed in March 2020 that was specifically addressed to that point. And I want to emphasise here that although these fears about being shut out of intensive care, for example, that were expressed by the disability community in Australia and elsewhere, have sometimes been dismissed as hyperbolic or unrealistic, it's necessary to remember that they're grounded in a history and an international context and an Australian context of what can best be described as structural disableism. That means they're very far from a dystopian nightmare. We might talk about that later on. Next slide, please. So in the last 2.5 to 5 years, ever since COVID-19 reached Australia's shores, all those reports have consistently painted the same sort of picture of COVID's impact on people with disability and the impact of the pandemic measures too. Most widely known, of course, are the disproportionately high rates of infection, of illness and death, especially in residential disability care settings, and those have been the instances that have hit the headlines. Less well known are the ways in which outside of those settings, the pandemic measures have often had a disproportionately severe effect on already isolated and marginalised people, with predictable consequences for their physical and their mental health. For example, pandemic measures, sometimes very abruptly implemented, meaning that essential supports, either professional carers or informal family support, have been suddenly removed. For example, in the case of one of my colleagues, having none of the 4 carers on whom she depended for food, water, toileting and mobility, simply not appearing on one day. There have been issues around information about the pandemic and about vaccination, about how to protect oneself, not being available in formats that were accessible to people with hearing impairment, visual impairment, or intellectual disability. Having said that, there have been cases of very good accessibility, in particular the use of Auslan interpretation at most press conferences and public health announcements. As we now know from some of the evidence given by the Department of Health to the Disability Royal Commission in autumn 2020, there was an effective but unannounced, at least initially, deprioritisation of people with disability in the vaccine rollout plan. They were initially, as we've heard, in phase 1A, but were shunted downwards effectively later on in 2020. There's a failure, I think, to recognise the fact that people dependent on care workers were simply unable to follow umbrella instructions to isolate, and were often generally in a position, not in a position where they could insist that people entering their homes were COVID-free or vaccinated or wearing masks. One of the things that's most been mentioned to me anecdotally was the very well-meaning, I think, but clumsy highlighting of underlying conditions when reporting COVID deaths as a factor in those deaths. I say well-meaning because it was about emphasising, I think, the vulnerability of people with particular underlying conditions, but it felt to many people with disability like an attempt to minimise the importance of those deaths. One friend said to me, and I apologise for the bluntness of this statement, it feels like they're actually saying it's no bad thing to have a bit of a cull at the moment. Most recently, also, the restrictions like masking and movement have been lifted, sometimes without much attention paid to people with disability who remain more vulnerable and who it seems are now expected to, quote, exercise personal responsibility by continuing to live a highly constrained life in order that others can go back to an apparent normality. Next slide, please. Aside from these very concrete, practical, tangible consequences, much less reported and less obvious are other consequences of this narrative as experienced by people with disability that are in many ways less easily repaired and less easily dealt with in the future than those material impacts I've just highlighted. And principally among these, we're looking at a massive loss of trust and confidence, 2 words we've already heard this morning, in government overall, and loss of trust and confidence in the healthcare services' ability and even desire to keep people with disabilities safe. The belief or the trust that there is some form of social solidarity with the most vulnerable, that disabled people are recognised as holders of human rights, and that people with disability are valued as something more than just a social burden or liability, has been severely damaged. And this message comes over again and again in the official reports of DRC hearings and more anecdotally in what the community is saying. And next slide, please. It's absolutely important that we face this and not try to find excuses for it or minimize it, because we do actually know now, even if we didn't at the outset of the pandemic, we know what to do better next time, and we all know there will be a next time. Report after report say the same things about the need to begin by listening to people with disability and liaising with disabled people's organisations, and to do that prior to the next emergency and not start from a position that on the outside we know in advance what's needed. Ensuring that public health communications are accessible and that they're directed to people with disability themselves. Far too much of the public health messaging about COVID measures were actually directed at carers in the last years. Recognising that disability is a hugely heterogeneous experience, that it's dynamic and it's contextual, and trying to get away from a sort of stereotype that envisages people with disability, perhaps as other vulnerable groups, as a distinct group who can be sort of safely parked over there while the rest of the community is managed and supported. People with disability are the community with some additional needs and quirks. One thing that continues to hinder our understanding of the experience of COVID for people with disability is the absolutely abysmal lack of accurate and available data. For example, it's almost impossible to interrogate mortality statistics for disability status or to understand how disability intersects with other marginalities. We need to ensure that the positive gains, and there have been many that were made during the pandemic in terms of accessibility, like the availability of information in Auslan or digital access to healthcare, telehealth and so on, ensuring that those are maintained and not lost in a return to business as usual. And finally, however difficult it is, I think we need to acknowledge the ongoing reality of systemic disableism in Australia. And that is the discrimination against, hostility towards, sometimes even revulsion about people with disability that runs like a thread, I think, through our societies and organisations. We need to be aware of the potential for damage and to guard against its effects. Thank you for listening to me, and I apologise for next door neighbour's dog who unfortunately couldn't be muted.
Thank you, Jackie. I think you said muted and not neutered, but thank you. As always, incredibly elegant, concise, and drawing together empirical data with some really important concepts, and leaving us with a really important part of today's discussion, which is the notion that pandemic or public health emergencies expose underlying currents or social issues like disableism. So Jackie, thank you again. So our third speaker is Mike Stevens. Mike is Director of Medicines Policy and Programs at NACCHO, which is the National Aboriginal Community Controlled Health Organisations. Mike is a pharmacist by profession before becoming an advocate, an administrator, an organiser, and politician, using that term broadly. Mike's worked in Aboriginal and Torres Strait Islander health sector as a policy advisor, managing programs, including in research and medicines policy, for more than a decade. In this capacity, he's provided policy advice to all levels of government, including to the Commonwealth Government and to a range of national agencies. Mike, thank you for presenting today.
Thanks very much. I take it you can see my screen now. I'm sharing. All right, so to start with, I'd like to acknowledge that I'm on Palawa country in Tasmania, unceded land. I pay my respects to the Tasmanian Aboriginal people who have the pleasure of living and working on. So as Ian's alluded to, I work for the National Aboriginal Community Controlled Health Organisation, NACCHO. I've had the privilege of working on, or kind of sitting within an advisory group and providing advice to some of our leaders. So to start with, I'd also like to acknowledge any Aboriginal and Torres Strait Islander people who might be joining us today, but also the Aboriginal people who've helped me prepare this information, and namely Dr. Lorraine Anderson, who's a general practitioner and a Palawa woman who works in the Kimberley, and Dr. Dawn Casey, our Deputy CEO as well. So I guess I want to dig down into some of the practical elements of equity. Equity is a huge issue in our sector. And I guess just unpack that a little bit. Michael Kidd has alluded to some of those issues in describing the Commonwealth's response. And so I'm just hoping to unpack that a little bit more and explain how things played out for our sector. To start with, I'd like to focus on the Aboriginal and Torres Strait Islander COVID-19 advisory group, which, as Michael had alluded to, was a really important part of the planning and intensive planning that was needed to manage this pandemic. It formed pretty early on, which was really important because there are obviously lots of emergent and dynamic issues. Again, going back to what Michael said about segmentation, the communication was a really important part of this. So I think getting the governance process to filter down into that communication was important. And also the messaging and the trust of that information, also having good governance really helped in that regard. So the meetings were held weekly for this group, which was kind of consistent, I suppose, with the COVID environment. I know there are probably some teams who are meeting daily or even more frequently than that. But to date, well, I'll explain what's happened with the group, but there's been over 100 meetings of this group, and they would last for several hours. It was probably one of the most important parts of this, which relates to maybe a principal mechanism for addressing equity of the Commonwealth Government, is related to the National Closing the Gap Agreement and the priority reforms which are in that agreement for our sector. One of which of those 4 priority reforms relates to community control and shared decision making. And as I mentioned earlier, Dr. Dawn Casey is our Deputy CEO and was the co-chair of this group, which we don't necessarily find in dealing with a lot of branches or parts of the Department of Health. We get a co-chair kind of role, and I think this was such an important part. The other thing was that it was really well resourced by the Commonwealth, who actually provided a lot of secretariat and coordination of a lot of activities. And the other chair was Dr. Lucas Detoka, who shrewdly by the department had been a medical officer within a community-controlled Aboriginal health organisation prior to his appointment in the department. So probably some other key parts that really helped address some of those issues that Michael's talking about in terms of planning and communication was the constituents of the group were very broad and included subject matter experts who had expertise, Aboriginal man who has an expertise in communicable disease, for example. There were representatives from state and territory governments as well. There were also clinicians, including Lorraine Anderson, who had that on the ground expertise. It's quite a large group, but I think because it was well resourced, it allowed the group to be quite functional and I think ultimately effective. I guess what has happened to this group now, which I think is a real success story of this model, is that this group has now in some ways transitioned into becoming a broader Aboriginal and Torres Strait Islander Health Protection Committee, and that now feeds up through the other health committee processes into ministers to advise on a range of communicable disease issues. So I think it has manifestly delivered and is now kind of seen as part of the architecture of Australian health policy, which is excellent. And a really nice way of enshrining that equity within our health system. Some of the key issues, I suppose, that the group had to deal with, one which is a common issue for our sector more generally, is around informed consent. And consent is probably sometimes seen as quite a binary kind of process, but there's lots of dimensions in our sector in relation to consent, and it's a real ethical challenge for a whole range of programs as well as research, and how a common issue that we hear about is the translation of information, not just in a literal language translation, but also how do communities actually convey information to their clients, both on a macro level, but also on an individual level. You know, are there specific messages that need to be tailored at a community level, which certainly was the case, and the committee really had the remit, I suppose, to support individual services to be able to develop the right communication, both in relation to vaccine, but also clinical care and some other aspects of actually managing COVID. So that was a really important part of it. And I suppose going to the nature of the group and considering these priority reforms that I've referred to, the idea of community control is really such a central component of achieving equity. When you have a kind of mainstream national algorithmic approach to healthcare, you can really miss out on nuances or things that are important in local communities. And we operate in an environment where we have 144 Aboriginal community controlled health organisations who are autonomous and represent their own communities. And we really try to engage and empower those communities to and support them really to provide services and communication that's relevant and appropriate for their own needs. And, you know, vaccination was, you know, almost famously, I suppose, a real challenge to ensure that there was that distribution. And a lot of resources were really put into doing that. And there were also a series of COVID grants, which went specifically to communities to be able to engage their communities and improve vaccination uptake, but also just more general COVID education as well. All right. Just a couple of other kind of ethical challenges, I suppose. You know, we certainly were fortunate to have the states and territories involved. For example, one challenge is around the scope of practice to allow adequate vaccination coverage in communities. There was an issue in terms of, well, which practitioners can actually provide vaccinations in this really important environment of trying to boost vaccination uptake. So, you know, there's certainly discussions with states and territories around how legislation could be improved to improve equity. And also I wanted to include somewhat of a story around, I just wanted to include sausages in a presentation. I've never had that word in a presentation before. Essentially, the Therapeutics Goods Administration have regulations around how vaccinations can be promoted, and we really wanted to support our members to do that. And a common community measure that our communities very much value is to have a community kind of day, sometimes which includes sausage sizzles. And the idea that was somehow an inducement for vaccination was something that we really had to work through as a sector, and eventually we were allowed to have sausage sizzles to promote vaccinations. So as I've discussed, there were some issues around consent, and I think autonomy really came into this, and it's a broader issue obviously than for the Aboriginal and Torres Strait Islander sector, but I think often in considering consent, there's a community, almost a community level decision making that can occur, and leveraging off that community authority and that community control, I think it can help improve that environment for helping people come to the right decision about what the right decision that they want to make is. The other thing, I suppose, is, as I've mentioned, that to have that balance or fairness, clearly in some areas where there's constrained resources, it requires an enhanced funding mechanism. And the COVID grants, which were subsidised by the Commonwealth, were very much supportive of really improving that environment for areas where the resources weren't there. And they were flexible enough that they really allowed communities to use resources in a way that were the most effective and efficient for their needs. I guess beyond the community control sector, certainly other issues that were identified, which again are probably common to COVID, ethical challenges more generally. Maybe one example is consideration of triaging or evacuation, and you know, how a clinician may consider, one clinician may consider the importance of someone's age, whereas you know, an Aboriginal community, for example, an elder who may not necessarily be a young person, but the custodian of knowledge and culture, you know, in terms of triaging which people will we evacuate, having a community controlled or a you know, Aboriginal and Torres Strait Islander input into some of these really important and very difficult decisions is important. And, you know, it's a challenge, I think, not just for the system, but for individual practitioners as well, across a whole range of environments. Thanks.
Okay, thanks, Mike. Then, and I mean, again, you've put that beautifully into its context, pointing out that the pandemic response is embedded, particularly in relation to Aboriginal and Torres Strait Islander health sector, is embedded in its particular political, social, and economic history, right? And that there was a much broader necessity, therefore, to address all of these issues. And I think perhaps where you alluded to at the end is seeing those things that can be retained as sources of knowledge, not just for benefit to the Aboriginal and Torres Strait Islander health sector, but also more broadly through the community as well. So our final speaker then is Kathie Melocco. Kathie is the founder of WOW Self-Care School and has previously regularly supported victims and survivors of sexual harassment, domestic and family abuse, and often forgotten cohort injured workers. Prior to working in these fields, she was a public relations and social justice practitioner and led the MBF breast health campaign that won the United Nations Award for communicating priority issues. Kathie has a long background in an interest in moral injury and both in systemic and structural harm. Kathie spoke out famously when her vaccinated parents both contracted COVID-19 in a Sydney aged care facility during mid-2021. And during that time, she, by accident, I think is her own words, became the family media spokesperson. She says at the time it was all about love and about focusing on getting everyone vaccinated. Kathie, welcome.
Thank you very much. Well, I'm coming today from Gadigal land, and I'd like to acknowledge the traditional owners. Before I start, I'd just like to reflect for a moment on the stats that Ian opened this discussion with. 15,000 Australians have died. That is a very big number, and multiply that by families, friends, and people impacted by those deaths. Many of those people were unable to say goodbye. Funerals were disrupted. People were finding it difficult to get home. We saw what played out on televisions across the world in Italy and in New York. In fact, what Ian didn't say in the opening, I run WOW Self-Care School. WOW stands for World of Work, and it was set up prior to COVID, just before we were researching that as part of WOW Chaplaincy, which is like our parent organisation, which is workplace related. And what was interesting is the world learned how to self-care big time during COVID. We all learned how to wash our hands. We all learned about wearing face masks. We all learned about social distancing and how we could contribute. But the Victoria University and the Mitchell Institute brought out a study, which you're very welcome to download, or it's included at the end of this presentation, on the state of self-care in Australia, which is what all those measures were. And they noted that it is one of the greatest major gaps in Australia's healthcare policy framework. In other words, what we then learnt through media coverage of people not having breast cancer screens and other regular screenings, they were disrupted, of course, during the COVID pandemic, and which continues. So I'm going to chat a little bit today about my own experience, and I became the news. It was not my intention to be the news, but in our work, and I'll just touch on that before I talk about my parents' situation, we've worked extensively with prison populations, and we know from our own work that many prisoners anecdotally were reporting that they were drug-free for the first time in their life because visitation rights were stopped and people weren't taking in drugs. The people we support with domestic and family violence, many of those, and it's been well researched at the moment, are reporting that they were being financially abused during COVID. They were locked in with their abusers, and some of those were unable to access healthcare appointments, regular follow-ups with treating psychologists, GPs, and so forth. The cohort that we do the most work with is injured workers, which is part of Australia's social insurance framework. And I have to say, from my own experience, they were forgotten. The only support that they really got was being allowed to have telehealth appointments with their GP to get their certificates of capacity to continue the small amount of weekly wages that they received. Lots of rehabilitation programs were cancelled, and of course we have the many issues that go on with an insurer, very often directing health applications. In aged care, Michael Kidd well articulated, and indeed he came to one of the aged care briefings that I attended for my parents. But we might just talk about what actually happened. If we could go to the next slide, please. So it all started with a tweet one Sunday afternoon, and I wasn't particularly active on Twitter at that particular time. Both my parents were vaccinated in summer care in Sydney. Both were very frail, but cognitively very able and very with it. And the environment they were living as we all have heard played out copiously across the media, is they were frightened. They saw what happened overseas on television. When my father tested positive, they were removed to Westmead Hospital. And I will pause there for a moment because it hasn't really been acknowledged in these sessions, but above and beyond, you all work so incredibly hard. So a big thank you to you all. But the politicalisation of aged care was very difficult as a family member. And when I spoke out, my mother was removed to hospital as well. It was in June 2021. So it hadn't really erupted in terms of all of the deaths that played out after that fact. But I discovered that quite by accident, as did the media, aged care workers were not being vaccinated to the degree that had been promised. Now, there was a lot of blame going on, with each party blaming the other side, has been well played out again. And the aged care facility actually employed a PR agency to manage me during the crisis, until they realised that we were all talking common sense and there was a need for lived experience of family members to speak out about aged care. The difficulty is the media needed a spokesperson, frankly. They needed someone to talk. So I found myself thrust into talking to many families and was bombarded. At one point, I got up one morning and I had something like 750 emails from families who were distressed. And I wanted to stop here ethically about the trauma that impacted not just the aged care resident, but also the families. And we're talking about multi-generations. If we could go to the next slide, please. And we're talking about grandchildren, we're talking about families and friends, we're talking about daughters, sons, and carers. We were all impacted because our loved ones were out of reach. And as has been pointed out during these sessions, many, the restrictions on seeing them was diabolical, and it has caused immeasurable pain and suffering. And many of those people have passed, having lived through that trauma. When I caught up with my parents eventually after 7 or 8 weeks after they were released from Westmead Hospital, it was like greeting people that had just stumbled out of a war zone. What had happened? So the lack of trauma counselling that was available to many families and to many other segments is perhaps something that we need to learn from this and to move forward. It is not the same as regular counselling. People need support in those areas. If we could move on to the next slide. So one of the areas that I particularly work in is in moral injury, and I hosted the Moral Injury Conference Pandemic Beyond this year, and next year it will be on climate change. But healthcare workers are all talking about vicarious trauma, burnout, and moral injury. What we're not really learning from this experience is about the community's moral injury. And if we could go to the next slide. Moral injury is essentially, it was first identified by Jonathan Shea, who was a psychiatrist that found Vietnam veterans were not actually recovering. And he looked at what was actually going on, and he identified it as moral injury. It is now a multidisciplinary research area. It's very early days in terms of treatment. As a chaplain, I'm involved in that area quite extensively. Moving forward, can we have the next slide, please? So generally speaking, what really causes moral injury? Well, politicians perceived as lying, and during the pandemic, there was a wave of total trust initially, but that trust broke down when we found out the vaccines weren't being rolled out fast enough. And there was, if you like, conflict between our healthcare professionals talking to us and what we've been told politically. So consumers were reading into it, making up our own mind. Domestic and family violence victims talk about, they're not getting support from police when they need it, particularly during the pandemic. And healthcare workers, as we know, were made to make, in particularly overseas, life and death decisions, which compromise the whole process of care and their training. So essentially, moral injury is a failure and a betrayal of leadership. And as I move forward, if we go to the next slide, and you'll remember what I said when I recapped on Ian's comment that 15,000 Australians have died. We have had bushfires, we have had flood after flood, we have had people losing jobs, people losing their businesses. One thing are people losing loved ones and not able to attend funerals. Not once in the conversation recently have I heard grief and loss mentioned. And they're the things we're talking about. They're the things that people need support to move forward. All the great work we've done during the pandemic, all the extra support everyone has put in place, unless we have a healthy population economically, we cannot recover, and people need time to recover. So if we go to the last slide, I posed the question to everyone. When September the 11th happened, the world mourned, and the world initiated massive healing ceremonies, massive validation, acknowledgement for the families. When Bali happened and the 20th anniversary, the same thing happened. I've yet to hear from anyone the need for a healing ceremony or an acknowledgement or a public ritual to acknowledge what people have been through so that we can move forward. Thank you.
Thank you so much, Kathie, for that enormously eloquent, heartfelt, and insightful and erudite sharing of information and presentation. And you've left us, of course, with a question, which is a great way for us to begin our conversation. We have just under half an hour for discussion. I'm going to invite all of the panelists to resume their videos on and be prepared to unmute so that we can talk together. Questions are very welcome, of course, from the audience. Please do use the Q&A function at the bottom of your screens. And I would love to just remind people, in case they can't see them, that we have our fantastic interpreters who can be visible on your screen. You might need to scroll along your view or to shape your view so you can see that. So what wonderful presentations, all of them succinct, all of them highlighting both the strengths, the many strengths that we have discovered through the process of the pandemic and that we have brought to this particular table. I think I'd like to begin with that strengths-based framing that you, Michael Kidd, laid out so well for us at the beginning. To use it to particularly perhaps respond to Jackie and to Kathie in particular, because what they've brought forward is the really also important need to both hold the strengths in view whilst giving a lot of acknowledgement to the deep forms of distress that various people have experienced, particularly in relation to aged care and disability, on an ongoing basis as a result of feeling to some extent expendable. And that occurred despite the fact that people went to the great lengths that you've identified to look after those groups on the basis of equitable issues. So maybe we could begin with that disjunction as part of our conversation. Over to you, Michael.
Yeah, thank you, Claire, and thank you to Kathie and Jackie and Mike as well on wonderful insights shared through those presentations. So, what I outlined was, here's the planning, here's the structures put in place, here's the responses which occurred. And I think it is really very important to have these discussions, to have about what worked well, what didn't, and particularly as we've been highlighting through this this symposium, who are the people who missed out, regardless of good intent, regardless of trying to make sure that didn't happen. Now, one of the things which really concerned me early in the vaccine rollout was when we were talking about opening up the country when we had 80% of the population double vaccinated. And my immediate concern, which I'm sure was shared by most people on this call, was what about the other 20%? And who would that other 20% be made up of? And of course, it would not all be people who were fundamentally opposed to vaccination at all. It would be the people that we've been talking about today, the people who had missed out on public health messages, the people who did not have access to the many sites where vaccines were being delivered, did not have access to a local GP or community nurse or pharmacist who could come into their own home and deliver the vaccines. So I think we still have to keep learning about where are these gaps in society, and sometimes it's not government-run initiatives which are going to address those gaps. What we've seen through the vaccine program, and one of the reasons why the vaccine program, the majority of vaccines have been delivered through general practitioners, mainly by general practice nurses and other community nurses and pharmacies, is because we wanted to provide the vaccines where people were. And what we saw, we had these big centralized vaccination hubs established in some of our major cities. But the majority of vaccines, people went to their local pharmacist or their local GP to get it because that was accessible. We have GPs and GP nurses going out now to aged care facilities for the booster vaccines and delivering on site. And that is a much more efficient way of and community focused way of delivering vaccines as well.
Jackie, can I perhaps invite you to, in a way, respond and perhaps say to us what do you think needs to happen to rebuild some of that terrible shattering of trust and exclusion from solidarity?
Well, it's a difficult one because it is so intangible, and we naturally tend to focus, and quite rightly focus, on what can be done practically to keep people safe and so on. I think there is a curious issue that needs to be addressed in the sense that, you know, at some level we all want to believe that we don't need to look at this anymore. Whenever there has been some kind of natural disaster or a conflict or whatever, you know, we know from past practice that there's a natural human tendency to want to say, well, that's over now, thank goodness, and we've survived. We draw a line and look forward. We've seen throughout this pandemic that there have been resources available from previous pandemics and other resources, and sometimes work that's gone on during the pandemic, which has been you know, misplaced, ignored, not been put into effect for an awful lot of reasons. Sometimes it has been lack of resources, sometimes it's been lack of clarity about what is actually the right thing to do in a very dynamic situation. But you know, part of it is, I think, going to be having the courage, really, for all of us to say, actually, life is never going to be again quite what it was before the pandemic, which none of us want to think about, but that is the truth. And that in some ways, as some people were saying during the pandemic, things could be better afterwards if only we take on board some of the things that we could learn and some of the messages. Now, there are many, many ways, many occasions in which it was people with disability were included, were in a better position than they might have expected to be. And I think certainly the speed with which the federal government put out its management and operational plan and so on way back in 2020 was quite exemplary. Many other countries didn't get their act together around people with disability at that speed or at all. So those are the sorts of real positives that we can be looking at. You know, what went right there? Well, one of the things that went right was perhaps much better coordination than we're used to seeing sometimes across the states in Australia. And that might be something to hold on to and build from.
Kathie, did you also want to comment?
Yeah, I mean, I echo what Jackie said about life is not going to be the same. It'll be different. And we've got a different version of living in Australia, in the world, on planet Earth. So I think we need to acknowledge that. I also think what we did witness and learn, that the silos that were in place, it was quite clear which silos were working really hard to overcome that and work together. But there was a disjointed approach from time to time. A really good example of that is the mental health communication, which kicked in at a certain point in time and was really great. And people were encouraged to stay connected and do all of those things. But as we moved forward, it's gone very quiet. And we are in, if you like, a recovery mode, and we do need to help people. You don't just get over this. You know, you've got to find a new way of living that, and trauma on top of trauma on top of trauma. It's not sustainable unless there is a great deal more support.
Thank you, Kathie. Just in the Q&A that are coming in, and I might invite Mike Stevens to be our first respondent, and other panelists. You know, the conversation between the four of you is very valuable, so you're welcome to, with just four of you, you can interrupt each other and jump in if you want to. But the first question in the chat is one that could be given a strengths-based answer, which is this question of, you know, we do know in advance that pandemics run through the inequities of populations. That's not a new finding. We know that already. We already know that that's going to be a central driver of pandemic outcomes, and it has been so here. So how do we learn lessons regarding equity so as not to repeat this, so not to feel surprised by this, or not to how do we maintain concern for equity between pandemics is the real question on the table. And we can see perhaps, Mike Stevens, that on the one hand, you've outlined one of the greatest strengths-based stories of the pandemic, I think, and yet on the other hand, we continue to struggle now in this period of reopening with the differential impact of COVID on Aboriginal and Torres Strait Islander communities.
Yeah, I mean, I think there's maybe going a bit to what Michael was talking about, the ethical imperative to publish. Certainly, I think that monitoring and evaluation, you know, is really, I guess those terms can seem a bit glib sometimes, but it's very important. And transmitting and working, communicating with communities, I think is really important. What worked well, what didn't. And I think, I guess just going to the last point about, you know, what now almost, in some ways, you know, I think the end has been a bit indistinct. We're clearly not at the end yet, but, you know, for a lot of our members, the community-controlled Aboriginal organisations, they had 99 problems before this started, and it's a bit almost like they just applied a pressure to that wound of all the other things they've got to do, and now they've got to take their hand off and actually deal with everything else that they were kind of trying to deal with before the pandemic started. So I think in some ways, maybe that's why there hasn't necessarily been a response from the health sector more generally around kind of reflection or just taking a chance to breathe, because there's so many other things that we're trying to do. I suppose just reflecting on the kind of what can we learn, you know, AEHA, the Australian Indigenous Doctors Association, highlighted previous pandemics and their effect they've had on Aboriginal and Torres Strait Islander people. I think we can certainly have some learnings, and they've tried to capture that in their ethical framework, which they've published. So I think it is part of a consideration. As I said, I think publishing and communicating is really important. I think maybe one of the things that this principal committee that I've referenced could do is really start to work at, and I'm not necessarily privy to all of the communication within that group, but really start to look at understanding what worked and what didn't work. And you know, with the impact that group can have, I think they could be quite influential, I suppose, in what are the next steps, what's published, how to engage with the community to kind of consider what worked well. You know, I think I'm really confident the therapeutics, the COVID antivirals, is a success story that we can learn from. You know, the government and the PBAC really took a great approach in terms of expediting things, but also improving that accessibility for Aboriginal and Torres Strait Islander people, as well as making the stockpile, the national stockpile, available. And I'm really confident that that's had a disproportionate, in a good way, impact on Aboriginal and Torres Strait Islander people who needed those antivirals quickly. So I think that's a positive lesson we can certainly learn from this.
Thank you. So I might take what you've just said and let it lead us to the next question that has been posed to us, which is that we all know that a community response is imperative to enabling equity, and the Aboriginal and Torres Strait Islander COVID-19 Committee is just an exemplification of that, and in particular the role of key health workers who have that interface right on the ground in that committee was really a key component of that. To me, this is a hugely important question. What's the best forum? State health government, healthcare agencies, independent community groups to achieve the changes required? How do we have more of that community response feeding into how the response is managed? Do we see opportunities to utilise the model that's provided there in other areas, perhaps with cold communities, or with disabilities sector? So Michael Kidd, perhaps you want to comment on where you see there is room for give. And Jackie and Kathie, if you have responses, please do jump in.
Thank you, and thanks for the comments which have come through as well. The voice of affected people and the members of affected communities is just so important. And obviously prior to the pandemic, there were many representative groups, advocacy groups and other organisations working closely with government, both the federal level and state and territory governments. And one of the reasons we were able to very quickly bring together these groups to support different priority populations and hear what was happening on the ground was because those links already existed, but they can always be strengthened. And I think that we need to make sure that we don't lose some of them. It's been wonderful seeing the mainstreaming of the Aboriginal and Torres Strait Islander advisory group that Mike has mentioned becoming a formal committee of the Australian Health Protection Principle Committee. That means it will be enduring, it will continue. The same has happened with the Aged Care Advisory Committee, which now sits formally under the AHPPC. I'd argue that we need to look very closely at what other groups need to have those voices getting into those important levels. The AHPPC bringing together the Chief Health Officers from each of the states and territories with the Commonwealth Chief Medical Officer, Chief Nursing Officer and others. I think, you know, again, it existed before, but it only met 2 or 3 times a year to talk about public health imperatives. Of course, it was meeting once, if not 2 or 3 times a day throughout times during the pandemic, and has provided that forum. But again, that will move away. One of the opportunities we have with the new government is the decision about establishing a Centre for Disease Control in Australia. And we all have the opportunity now to determine what that will look like and how it will meet the needs of the Australian population, both during times of national emergency, but also between those national emergencies as well. So I think it is going to be a really important time for people to express what they think is going to work best to make sure that we have as much equity as we possibly can in our future responses.
Thank you. Jackie or Kathie?
I agree with Michael. I also think we've got to be careful not to hear what we want to hear. And he's raised the point about more voices, you know, let's get to the grassroots and find out how people actually were responding and what they were going through. I've highlighted one group with the injured workers, and they were subject to a Four Corners report during COVID, and yet still they were left out. But there's some practical things that we could do using interagencies. For example, we've got Seniors Week that happens all around Australia. We have NAIDOC Week. Let's feed into those opportunities and actually ask for grassroots feedback that we wouldn't normally get, and see, you know, look at that data and see what comes out of that, and do we need to go investigate further?
Thank you, Kathie. Yeah, Jackie.
Yeah, I think we're all aware that one of the problems is the disconnect between different agencies, different community groups, different perspectives and different insights. What we need to be doing, I think, is trying to join those dots up as much as possible, and gathering all that information up and feeding it into the right place. I know that, you know, transparency is a kind of a bit of a buzzword nowadays. It means different things to different people. But one of the things that I felt was very noticeable during COVID was the differences in different kinds of public health and government messages and people's responses to them. In that we all know we were in a situation in which there was very little information to start with. That information about the disease and its progress and how to protect against it kept changing. There was often a bit of a reluctance, I felt, just to say we don't know, you know, to say very honestly and openly, we're doing the best we can, but we don't actually know very much at the moment. And I do think that officialdom tends to be like that and try to maintain its status, but that people at the grassroots, at the cutting edge, at the, you know, the pointy end, however you want to put it, tend to be much more forgiving if they feel that they're being treated honestly and with respect, and that what they're being told one week doesn't suddenly change without explanation, the next week, because those decisions about, let's say, the deprioritization of people with disability and the vaccine rollout, it's a complex and difficult decision. The main reason for the negative response, I think, by people with disability was that nobody said anything. Nobody consulted, it just happened. And if there had been discussion and consultation, then I think it would have been a lot more understandable.
Thank you, Jackie. I feel like that was an experience that many people shared, that sense of whether they were teachers or people who are retail workers or in supermarkets or cleaners in hotel quarantines, often had that sense of feeling like they were not empowered by having some representation of their concerns in the public arena. And perhaps that's a really strong form of distress that we carry towards the future, and remains one of the lingering challenges that you and Kathie have both referred to. And I want to acknowledge at this moment what Kathie has said also, which is the degree to which healthcare workers in particular, and all of those who were on the front lines of pandemic response, have not yet had an opportunity to process or engage with many of those feelings or those experiences. And in acknowledging that, I know we're towards the end of our time, and Ian has been responding to some of the questions in the chat. Did you want to raise one final one? Because I was going to give everybody just one last minute as speakers to say something about what we need to do to move towards the healing that Kathie was indicating before we need to bring this to a close. Are you comfortable with that, Ian, or did you want to raise a question?
No, I'll raise nothing at all. I'll type.
Okay, so Ian will type the responses in the chat, which is why we have you, Ian. Thank you. And thank you for your questions in the chat from our contributors. I really appreciate it. And obviously this is the beginning of a conversation that we are all hungry to have the space and time to have. And that's why we're running out of time now. But over to our panelists, very, very briefly, each in turn, to move towards the healing that Kathie spoke of so eloquently in her presentation. What is the most important thing that you feel that we need to do? And we might go first to you, Jackie, and then to Michael Kidd, and then Michael Stevens, and Kathie, you can conclude.
There are lots of things that are necessary to do, but perhaps one of the most important is actually to do something, because there have been so many reports, many of them saying the same thing. There will be other reports for sure, but there's a sense in which we retread the same ground before, and what we actually need to do is to have plans in place.
Thank you, Jackie. Michael Kidd.
Look, thank you to everyone, because I've gained some really valuable insights today, and also thank you to our Auslan interpreters for keeping up so brilliantly. I think this issue of healing is really important, especially for our healthcare workers, and it is one of those lessons from past epidemics and pandemics that people do experience terrible trauma, and often will leave their work afterwards. And I don't think we've shown enough appreciation to our healthcare workers who kept working all the way through this pandemic, especially early days when personal protective equipment, there was a global shortage and people were at risk. I think our aged care workers that Kathie has mentioned, our disability care workers who've just kept working day in, day out, doing the very best they can. And often the work has been really hard when people have been wearing that full PPE during outbreaks and lockdowns. So I think that thank you to all those people is incredibly needed.
Thank you. Mike Stevens.
Thanks, Claire. Just again to reiterate the AEHA, Australian Indigenous Doctors Association, well, their third recommendation within their ethics in clinical triaging frameworks paper around COVID is around ongoing review. And I think, I guess it's just making that space for reflection for the sector. You know, I've just been at our national conference last week, and as I said, I think a lot of people are trying to get on with what they
Thank you. And Kathie, a last comment.
I think Jackie touched on it, and that is human beings sense authenticity. We know when we've been told something that's from the heart and it's genuine. And we know that everyone went above and beyond, did the best that they could. But there were mistakes and there were failings. And I think being able to do that in a manner where there's no blame, but people are acknowledged for how they're feeling and validated is incredibly important. Our healthcare workers are really suffering, and a lot of it is about, you know, systems they find themselves operating in, and we need to find a way forward without the bureaucracy to give them the space to heal.
Thank you so much, Kathie. It's time, sadly, for us to bring this all too short, just beginning of a taster of a conversation to a close. Could I invite the AEHA member and from Musculoskeletal Australia, Rob Anderson, and convener of this symposium, to bring us to a close and thank our speakers.
Thanks, Claire. Well, that was a fantastic discussion, and you're right, Claire. I think we've only scratched the surface there, but what an entertaining and engaging symposium. So, yes, I'm Rob Anderson, CEO of Musculoskeletal Australia. We're a consumer organisation. I'm on the steering committee for AEHA. That's how I was sort of roped into chairing the committee for this symposium. So, I've got a lot of people to thank, hugely grateful for everyone's participation today. Hugely grateful to Dr. Claire Hooker and Dr. Ian Kerridge, who moderated today's session. Our quality speakers, Professor Michael Kidd, Professor Jackie Leach Scully, Mr. Michael Stevens, and Miss Kathie Melocco. And thank you to our interpreters, as Michael indicated there, Dave Childs and Nicole Mayer. Thank you for your service and support and facilitation to today's exercise. I want to acknowledge and thank our AEHA Chair, Adrian Kerridge, not only in terms of his participation and coordination for this symposium, but his outstanding leadership of what is a world-leading organisation in this rarefied space. I particularly want to thank Talissa Trevelyan. She is you won't see her on the screen, she is the Alliance Manager and just does a magnificent job. Both her work ethic and professionalism is something that our organisation and I know steering committee members really appreciate. I thank everybody that's participated in registering and listening to today's discussion. And I want to encourage you to further engage with AEHA and also promote throughout your networks, because it's only together that we achieve these objectives. So the more of our sector that we can reach and the more we're talking about commonality around these issues such as today, the better it's going to be for people across our country. So with that, I thank you all.